Here in the Mount Sinai Health System, we have 7 hospitals, perform approximately 100,000 surgeries a year, and have some of the best operating room teams in the world.
Despite this expansive expertise, we're at risk for the occasional wrong-sided procedure, unintentionally retained foreign body, and miscommunications can happen every day.
A safe medical center results from a team effort. We, as a team, must support each other and communicate openly and accurately. The TeamSTEPPS program and the surgical safety checklist are tools that can help organize our conversations and make them more effective.
TeamSTEPPS is a government-funded, structured approach to communication and system-based team building with the goal of improving operating room team dynamics. Let's start simply and focus on a few high-impact key behaviors. The call-out is simply announcing important information that helps the team prepare or respond to a situation. A checkback is a type of closed-loop communication where the receiver of the information repeats back what he or she heard. This is especially useful when communicating information about medications, such as antibiotics. Many of us do this naturally each day, but there are certainly unrecognized opportunities for these techniques that we could take further advantage of.
Dr. Inabnet, we are having drop in blood pressure. CVP numbers are dropping. Did you ligate adrenal vein just now?
Yes, we just ligated the vein, and in fact, this is a Theo patient, so we anticipate the pressure is going to drop. But we do have some bleeding here.
Okay, Inga, can you take this blood gas for me? Get me 2 units of packed cells into the room, please.
Bringing 2 units of blood cells and ABG results.
Thank you.
The 2 challenge rule applies when important information is stated and ignored or disregarded. The communicator should politely repeat the information again and convey a sense of urgency if necessary.
Dr. Nabnet, I think the instrument became contaminated over his mask.
I think it's okay.
Are you sure? I'm concerned. It is contaminated.
All right, thanks. I'll change it and also replace my gloves.
You may be able to think of situations where if someone spoke up when they saw something bad happening, we could have avoided a problem. Don't be afraid to ask if you're concerned. If you see something, say something. Clear communication is essential to safe medical care. Use SBAR to relay information in a succinct, organized manner. Describe the situation and provide background information, then give your assessment and end with your recommendation.
Excuse me, Dr. Nadnit. I just saw the consult from the ED. So the patient's a 60-year-old female, post-op day 10 from a total thyroidectomy, presenting with chest pain. She was moving some furniture when she developed some new onset chest pressure. She has a cardiac history of stent placement in 2005. I think she's having some anginal symptoms from her heart disease. The ED is giving her some morphine, some supplemental oxygen, some aspirin, and some nitro, and getting an EKG as well as some blood work. I think we should get cardiology to see too.
That sounds like a good plan. Also, please have the ED team check a stat calcium as well as a thyroid panel, and please keep me posted.
The stat calcium and a thyroid panel? Got it.
In addition to the main operating rooms, Universal Protocol applies to procedures performed outside the operating room as well, for any procedure that exposes patients to more than minimal risk. Such procedures include those that involve puncture or incision of the skin, or insertion of an instrument or foreign material into the body. Some examples are percutaneous aspirations, biopsies, cardiac and vascular catheterizations, endoscopies, central line placement, thoracenteses, paracenteses, and lumbar punctures. Anesthesia procedures performed prior to surgical procedures such as regional nerve blocks or independently such as spinal facet blocks are included as well. Examples of procedures not included are venipuncture, peripheral IV placement, nasogastric tube, and Foley catheter placement. Locations in which these procedures are performed may include special procedure units, endoscopy units, cardiac catheterization or electrophysiology labs, interventional radiology suites, offices, the emergency room, or even the bedside. Perform a pre-procedure verification, timeout, and debrief using your designated checklist, which may look like this one. For procedures involving laterality, mark the site as described in this video. Refer to the Mount Sinai Health System Universal Protocol policy for further details.
We have revised our surgical safety checklist. Although it is important that we address each element on the checklist and sign our respective sections on the back of the page, we must emphasize that the checklist is not just a paper to check boxes off on. During the timeout and debrief, please stop whatever you're doing and make sure that everyone in the room is participating. We will achieve maximum benefit from the checklist if we use it properly. Please be an example for everyone.
The pre-procedural verification should be performed before practitioners begin anesthetic and surgical services for the patient. It is important to pause and verify key information such as patient identity, procedure, and site verification. Because of these and other important items, please complete this section prior to entering the operating room. Each practitioner team should address and complete their respective sections.
Hi, I'm Eric Jendon, System Chair of Otolaryngology Head and Neck Surgery. The attending physician or proceduralist must perform the site marking using his or her initials. For all sites involving laterality, paired organs, multiple structures such as fingers and toes, or multiple levels such as in spine surgery, the mark should be made in the following way. For unilateral surgery, mark the side of the surgery. For bilateral surgery, excluding explorations, mark both sides. For unilateral and possible bilateral surgery, mark the side of the initial intended surgery. Make the mark near the incision so that it's visible when the patient is prepped and draped. A silver wristband should be used for patients who refuse marking, for neonates, as the mark may cause a permanent tattoo, or problematic surgical sites, such as the perineum. The surgeon or proceduralist should place the wristband on the patient, and that wristband must have the name of the patient's date of birth, the procedure, and the anatomic site and laterality. Please note, the wristband may not be present on the actual side of the surgery. That's why the information is written on the wristband itself. The final verification of the site mark or wristband must take place during the timeout conversation.
Now let's talk about the timeout. This is something that many of us do very well already. It should be performed after prepping and draping, and just prior to incision. It can be led by anyone. Most importantly, in order to be effective, we must stop what we are doing and participate. Use this as a dedicated hiatus to gather the team to have a conversation about relevant aspects of the case. This is our last opportunity to check that everything is in order before we proceed.
Can everyone just stop what they're doing so we can do the timeout, please? I'm Dr. Susan Boble, attending surgeon.
I'm Megan Friedman, anesthesiology resident.
I'm Warner Meadows, attending anesthesiologist.
Keitaro Nakamoto, surgery resident.
Anne-Marie Barnett, scrub.
And my name is George Deuce, circulating nurse. So this is patient Miss Mary Jones, date of birth, January 1, 1980. Can we verify they have the correct imaging and pathology reports to confirm site and laterality?
Yes, this is patient Mary Jones, date of birth 1/1/1980. We will be doing a left breast partial mastectomy with needle localization and left sentinel lymph node biopsy.
The name Mary Jones and the date of birth 1/1/1980 also matches our anesthesia record.
Okay, so this patient is consented for a left breast partial mastectomy with needle localization and sentinel lymph node biopsy. The patient's in a supine position. Her elbows have been padded. And can everyone see the marked surgical site?
Yes, I see the mark on the left side.
Sufficient time elapsed for skin prep to dry and fire safety check.
The prep is dry and the patient is at low risk for fire.
And equipment implants available?
Yes, equipment is available.
Patient diagnosis, allergies, and patient condition verified.
Yes, this patient has a left breast mass. She has a left arm AV malformation. She has severe COPD, severe cardiac disease with stents. She has an allergy to heparin, and she's hepatitis C positive.
Okay, so DVT prophylaxis have been initiated and antibiotics given?
For now, we will not give heparin given her allergy. SCDs have been applied, and she received cefazolin 20 minutes ago.
Okay, so cefazolin has been given. Can we discuss any critical steps, including specimen handling?
Yes, the specimen will be sent to radiology for specimen radiograph. Do we have a board available?
Yes, we have a board available.
Okay, the only other thing to be aware of is that given the patient's history of the AV malformation, when we do the sentinel node biopsy and get into the axilla, We may get into some bleeding. Because of that, I do have vascular surgery on standby call.
Okay, and we're prepared for blood loss. We have 2 large bore IVs in place.
Is this patient going to PACU?
Let's see how she does. We may not extubate her given her severe COPD. In the interim, I will give the ICU a heads up and let them know we may require a bed post-op and a vent.
All right, so any comments, concerns that anyone would like to add?
Just a final reminder to be careful with Sharps as always, because she is hepatitis C positive.
Thank you again for a reminder. Everyone, please be careful, and do we all agree?
Agree.
Agreed? Okay.
The debrief conversation is important to make sure we have prepared for what the patient needs in the next phase of care. It's also an opportunity to talk about what we could have done better and for the team to provide feedback to one another.
Okay, can everyone just stop so we can do a quick debrief? Katara, just hang on 1 second so we can do this. Great, thank you. So we did a left breast partial mastectomy with preoperative needle localization and a left sentinel lymph node biopsy today.
And I do have 2 specimens, doctor. I have a left breast tissue marked 9 o'clock, short superior, long lateral. And the second one I also have is a left axillary sentinel lymph node biopsy, in formalin as well. Both of them for Mary Jones, date of birth January 1, 1980. Is that correct?
That is good.
Okay, and what is your antibiotic plan?
No further antibiotics post-op.
Okay, and DVT prophylaxis?
No heparin because of her allergies. We use compression stockings while she's in bed, and the patient has no Foley.
We gave 1 liter of fluid, and EBL was about 20 milliliters.
The patient does in fact have OSA, and given her latest blood gas, I prefer to keep intubated post-op. The ICU knows we need a bed.
Okay, if we're keeping her intubated, we'll put a Foley in.
And also, I just want to let you guys know the sponge, needle, and instrument counts are correct.
Great, counts are correct. I'll do the op note before I leave the OR.
Thank you for that. And Marie, did you have any equipment malfunctions?
There's a scissors in the tray that needs to be sharpened.
So you want to separate that? We'll have it marked so that it could be fixed. Anyone have any unexpected occurrences?
The plan was originally to extubate this patient. However, given her respiratory acidosis, we're leaving her intubated.
All right, and any room for improvements?
So she has a scratch on her lip from the intubation. We could have been more careful to move the lip out of the way during laryngoscopy. Overall, nice working with everyone. Great job today.
The only other thing is, in the future, we should probably call radiology and give them a heads up that the specimen will be on the way, and that way we can decrease the wait time. But overall, it was great. Thanks very much.
All right, thank you so much. Keep that noted.
Remember to encourage discussion and empower your team to speak up.
The checklist is a tool. It is not a substitute for vigilance and good practices.
Each member of the team plays a critical role to create a safe experience for our patients.
Thank you very much for your continued cooperation and dedication to improving patient safety.